Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by survivingbreastcancer.org. I am Laura Carfing, breast cancer survivor and founder of survivingbreastcancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Hello, my friends, and welcome to another episode of Breast Cancer Conversations. I am so excited you are here today because we are focusing on a critical topic important to all of us, nuclear medicine. I don't know about you, but anytime I'm going in for a scan and they are injecting me with radioactive dye, or I guess the technical term is called a tracer, but anytime I'm being injected with this radioactive juice, as we will talk about it, I can't help thinking about that Imagine Dragons song. I don't know. That song has become my soundtrack anytime I go in for a scan. These scans are critical for helping our medical care teams understand what our diagnosis is, and also for staging our diagnosis and follow-up scans. We might be getting scans every 3 months, every 6 months if you're living with metastatic disease. Today, I am joined with Dr. Kiser and Pam Kohl, who are going to take us behind the scenes from a medical and a patient advocate perspective. And I always say, I want as many people as possible looking at my case. The more eyes that are watching me, the better. And I think sometimes we put nuclear medicine kind of on the back burner because we're always so focused on our oncologist or our surgeon, and so I think being able to kind of go behind the scenes to really talk about the ins and outs of nuclear medicine and the role that that plays in breast cancer has been game changing. Welcome to the conversation. We're talking about nuclear medicine and these different agents that are being injected into the patients. A lot of times as someone diagnosed with breast cancer, we're and you mentioned, Dr. Kiser, your wife was going through adriamycin. I know a lot of our listeners, myself included, have gone through adriamycin and a lot of really harsh treatments. And we will do anything to kill the cancer, but there's a cost to that. There is a toxicity associated with that. So can we talk a little bit about maybe some of the safety and precautions when someone is going in for a nuclear medicine type of test?
Well, typically the doses that we give, so it's like if you're getting a CAT scan of your chest, okay, the biggest concern is a female is the dose to the breast. Well, most of our scans, like FDG and FES, they're not going to be biodistributed to those areas unless it's where the tumor is, right? So sensitive organs like ovaries and testicles and breasts and stuff like that, they typically are not, they're not as part of the follow-up, right? Because they just don't get that kind of dose because it's in the blood pool, it's going around, it's trying to find where it needs to go. Whereas when you do a CT scan, you're just going from here down to your liver, and it's just like a big blast. And now that we have these multi-slice scanners, it's called oversampling, so that we can do these reconstructions, so three-dimensional reconstructions that are very pretty as opposed to old school stuff. But they have to oversample the same tissue, in order to do that volumetric thing. And I know I'm getting a little ahead of myself, but it's a risk benefit thing that you have to think about. You've got breast cancer, you want to live. And if you were to develop a radiation-induced cancer from all these procedures, it's going to probably be before. It's not going to happen before something else happens, right? So what we worry about mostly is these young kids that have cancer, and they just get burned up with X-rays and CT scans and nuclear medicine stuff. But typically, the doses that we deliver are not that bad. Now, going back to the safety issue, one of the problems is, and I'll let Pam expound upon this because this is kind of a common topic for us, is this idea of extravasation. So that's the one thing where we get in trouble with nuclear medicine and PET. So you access a peripheral vein, you have this dose, it's radioactive stuff. And if you go outside the vein when you inject it, that's called extravasation. So it goes into the soft tissues around the vein. And it's usually a small volume of a high dose in this tissue. So the way we combat that is we adopted using a device by a company called Lucerno Dynamics. It's a sensor device that you can put near the injection site, and it shows you the integrity of your injection. So it kind of makes a curve, and you have a sensor on a reference arm, so the contralateral, the other arm, And what happens is you'll see it spike up if it's a good injection, and it'll come right back down. And then eventually the two lines, the reference sensor and the injection sensor, come together to be like the same line, basically. If you have an extravasation, that injection goes up, and it stays up, and it stays up, and it stays up, and eventually it drifts off because your lymphatic system will start taking that extravasation out. But we've done some studies and some research projects where we've looked at some infiltrated bone scans doses into the anticubital fossa, which is where most people get their IV set. And it's been upwards of 18 to 20 gray, which is a pretty big slug of radiation. Now, what are the long-term effects of that? I don't know. I mean, I probably won't know in my lifetime, because I'll probably be retired by the time these patients, if they do develop a cancer or sarcoma from that, manifest, but I still think, for me, the reason I started doing it wasn't so much patient safety. It was making sure the dose was delivered, because when we do FDG scans, we measure what's called SUV, standard uptake value. So if you think you got all that dose in there and you use that as part of the calculation, and like 90% is in the arm, then your SUV measurement is going to be artificially way lower than it should be. And we've proven this. So I've had patients that had severe extravasations. We brought them back, and so they may have an uptake value of, say, 3 on the initial scan, and it will jump up to 20 on the repeat scan. So it can mess up everything, especially in follow-up. So we get a good injection on the first staging study, and the patient comes back, we extravasate them, and we get like a much lower dose, or much lower reading rather. And we're like, oh, patient's responding. It's great. They had a greater than 50% change in their SUV. Well, actually, it's because we screwed up and we didn't get the dose into the system. And so if you bring that patient back, you'll say, oh, it's almost the same as it was pre-treatment. We need to change drugs here. Something's not working. And I get a lot of pushback from my peers and everything. They think I'm crazy that I do this, but I honestly believe it, and I've published multiple journal articles on this topic, that dose injection matters, and it's very important to us in our hospital system. So my hospital system, at least in PET for now, we're going to expand it out to nuclear medicine, but the two systems where we have PET scanners, we're using this device in order to make sure that our patients are getting good injections. And if they do have a bad injection and we know about it, then we can mitigate that. We can go in and kind of put compresses on there, try to like massage it, get it out of that area so that the lymphatics can kind of do their thing and pull it out of there, so there's not such a prolonged exposure of this high dose. And it's always possible. It's always possible you can do it, even with this device, and it helps us pick it up.
Without this device, how would someone know if they were extravasated?
Really, the only thing you can know that it's happened is if you put that body part where it was injected underneath the gamma camera and look and see if it's there. Or it's kind of hard in PET scan to do that, but certainly can do it under a gamma camera. And I've had like major debates about this, but that's really all you can do. And the other thing is, like, when people extravasate for a CAT scan, they're giving like a large volume, like say 90 cc's, 100 cc's, 120 cc's of contrast, and it's at a very high injection rate sometimes. Like if you're having like a scan for lung clots or blood clots in the lung, they're injecting like 4 or 5 cc's a second, which is a pretty fast infusion rate. Our volumes are about like half a cc, 1 cc, and I could inject both of you guys with that, and it will go straight into your soft tissue, and you never know it.
And, part of the issue is, just you won't necessarily know. And using this particular gadget from Lucerno, all of the things that Dr. Kiser said are true and so important. But in addition, it enables it keeps the data so that it enables Dr. Kiser or any institution to see where there needs to be new training, or it's a quality control kind of issue. So in response to your question about how would a patient know, sometimes a patient might know because there may be swelling in the area as it's going in, or there may be stinging, but most of the time, patients have no idea. And I've been extravasated for sure once, and I knew enough to say, I think something's wrong. Think something's wrong. It's not feeling like it typically has. And again, oh no, everything's fine. But I finally said, put my arm under an x-ray machine or something, and sure enough, there was a big blob of area right in my elbow area. I then knew that my scan probably wasn't going to be accurate. And again, for those of us who are metastatic and our treatment is based on our scans, those scans matter, whether you're getting them every 3 months or every 6 months. We're way past staging. We're about treatment. I can have an extravasation into my tissue, right? And that doesn't have to be reported to my oncologist, to the director of radiology, or to the Nuclear Regulatory Commission.
Or to even you, if it's happening.
Or to me, right, because most of the time people don't even know. But if a tiny drop of that, what I call the juice, the nuclear medicine drops on my shirt or on my gown, that has to be reported. That's something that is external to me, but if it's an extravasation within my body, it does not. That is not okay. And that is not being focused on patient safety. Now, we know that nobody likes to be regulated. And so the radiology societies and the hospitals do not want this regulation changed because they don't want to have to regulate it and have to know and notify patients. Of course, they're worried about lawsuits. Totally understand all of that. But we feel that if the Nuclear Regulatory Commission required a reporting, then that requires some accountability, which requires the institution to pay more attention, to find a way to make sure they know whether there's an extravasation. It's very similar to a decade ago or two when we advocated, so many women advocated that mammography machines need to be calibrated on a regular basis. And that was a hard fought legislation, and now we know that they are calibrated. That was a regulation that incentivized institutions to hold themselves accountable for patient safety first. We have not been successful with the Nuclear Regulatory Commission to do what needs to be done. So we now have a bill in Congress that has been introduced that will ask the Regulatory Commission to put patient safety first. And we're excited about that and are moving forward with getting a bill introduced that would.
Yes. And in the show notes of the podcast, I'm going to link to all of that information. So for anyone who's listening and is feeling empowered to become a sponsor and support this type of legislation, there'll be information available to you too.
I gotta share a funny story since we've been talking about this monitoring the injections and stuff. So there's a woman that is from where Chernobyl is. I'm blanking on where that is. I'm kind of bad. My geography is slipping away. But anyway, she was near the meltdown, and she ended up she moved to Texas and ended up developing thyroid cancer because that's like one of the byproducts of these nuclear meltdowns is I-131, which we use as radioactive material to treat thyroid cancer and hyperthyroidism. So she ended up developing thyroid cancer. So they wanted her to have a PET scan, and she was scared to death of the radiation. She said, I just can't do any more radiation. It's like I got thyroid cancer because of radiation. Oh, well, she did some research and she found one of the articles we had written, and she found out we're using this device. And so she asked her institution in Texas if they could use that device. They said, we don't need that. We don't ever infiltrate extravasate. So long story short, I told the CEO about this of Lucerna. I said, this kind of stinks. I mean, I said, I would love this lady to come to us and be treated, but she was on a limited budget and this sort of thing. She couldn't pay to come. So this company, it just, they decided they were going to go to her. and they went to Texas and monitored her. So, I mean, that's how dedicated they are. But I've been working with them, originally it was just kind of to help to see what we were doing wrong. I wasn't a believer in the product. I didn't know anything about it really. And then I see what it's done and how it's changed my practice. I'm a true believer, and I'm not endorsing them. I'm not here to make any endorsements. I'm just saying, but just like I believe my scanners that are made by Siemens, I just believe in this product, and we use it every single day on every patient we can. Unless they have a port in, they get this device put on them. So.
Pam, I believe you have another example, perhaps, that you can share with our listeners about a PET scan that you had where you were finished with your scans and then they came back in, or the technician came back in and said that they needed to rescan you. Can you tell us a little bit more about that?
I was finished and the technician came in and said, we need you to take your gown off and we need you to put your arms in a different place and we need to do another scan. At which point I said, have I been extravasated? And of course she was like, was not going to have any more conversation. She said, well, the doctor will tell you, but we need to rescan you just to see what's going on. So they rescanned me and she came out. I said, well, has there been an extravasation? She said, well, that the radiologist will look at both scans. And I knew the radiologist because I had asked him to have the Lucerno on me, and they said no anyway. So I emailed him. It was a Friday afternoon. Well, on my way home, I reached out to Lucerno because they're in Cary near Raleigh. And I said, how long can you tell? He said, well, when did you have the injection? I said, about an hour and a half ago. He said, we'll come over to your house. And they did use Lucerno and looked where the injection was and looked at my other arm. And I had 4 times more juice in my arm than in my other arm, which meant something was wrong. And, we assumed it was an extravasation. So I wrote the head of radiology and said, I know that we've had this test and now I know you're going to look at it. I'm nervous that I've had an extravasation, very nervous that the scans will be inaccurate. And I figured he wouldn't get back to me till the next week after he talked to the lawyers and stuff.
Sure.
He emailed me Friday night and said, he will look at it, blah, blah. On Monday, what happened was, since I've had lymph nodes removed, I can only have IVs in my left arm. So my veins are not great. I'm a difficult IV access patient. And what has happened is that my veins have become a web of veins in that area. So it was not extravasated. It stayed in my veins, but in that clump. Right. Just never got all the way through. So, and he looked very carefully at the scan and he felt confident that the scan was accurate. But, I, as a patient, because my veins are not great, always ask for an ultrasound for my IV because they just, and they don't want, the technicians can be very, I don't know whether it's ego or what. Oh, no, I can do it. Oh, no, I can do it. So he said, because we now know this problem with my veins, he's put it in my chart that I should never have an IV without an ultrasound at a minimum.
That's great.
So it's just, it's just so important. And it's such a solvable problem. I mean, Dr. Kiser has shown that using Lucerno's product, I'm sure there are other products that can do something similar, is so useful and important for patient safety. And it's an easy fix, right? And, it's very hard to convince institutions for whatever reason to take advantage of this.
Oh, well, hopefully, as we keep providing this type of information, real life stories, real life case studies, we can feel more empowered of maybe not necessarily what to look for, but what to ask for. And, I get this all the time. They're like, oh my gosh, Laura, like you have the podcast, you run survivingbreastcancer.org. Like you're like this huge advocate. And I'm like, when you're half naked in a Johnny sitting on cold metal, you feel about this big. And the guts it takes to advocate for yourself, to say something. I can't tell you how many times I've tried. Like, I know the script, I know the language, and I get a no. I'm like, oh, okay, just hurry up then and quickly do what you have to do so I can get dressed and get out of here. But it takes that question like again and again and again for you to finally say, like, I'm really serious about this. Like, I need to change something. Right. And so I share that story too, because I know it's not easy to take matters into your own hands. It's an additional patient burden. But at the same time, I'm really hopeful that our listeners can really take away from this that there are opportunities and there's different types of PET scans available to you. And there's a way to detect if your tumors in distant locations are ER positive, and that can help predict treatment. And that there are safety measures that can be put in place as well. And even if your hospital doesn't have this device that we've been talking about tonight, it's just for you to know, like, make sure that your arm is feeling well, that there's no swelling, that there's no sting or pain at the injection site. And then you can always ask your radiologist who's reading everything, like, how confident are we in these results? Because as you were mentioning, Pam, as a metastatic patient, this is like life or death. We're making life choices here based on my treatment. And so we need to have really solid information. So I appreciate tonight's conversation, you guys. This has been, again, I literally have like pages of notes over here. I'm not even lying. I went and got my pen. And I'm excited to like blog about this, write about this, have this on our podcast. But Dr. Kiser and Pam, are there any other topics or things about Cerianna FES PET? I know the terms are used interchangeably that we haven't covered or talked about that you want to share with our listeners. But I feel like we've gotten like a pretty good deep dive. So I appreciate that.
Yeah, the hardest part for me is trying to help people understand that have no real medical imaging knowledge. And so I kind of want to leave it at that. I try to dumb it down as much as I could. I don't mean that in a bad way, but I'll sit down and talk to patients, and I try to explain what we're doing, and it's just such a difficult concept. I mean, even I have these med students come in and trying to teach them, and they're going, they don't know what's happening. So this is a difficult area for people to understand. So I hope that at least 1% of this is understandable and digestible to the people that watch this. So.
And fortunately, like Dr. Kiser said, it's changing rapidly now. And what we say today, a year from now, there may be even new opportunities for really good testing and treatment.
Yeah. I mean, and I always say, like, I want as many people as possible looking at my case. The more eyes that are watching me, the better. And I think sometimes we put nuclear medicine kind of on the back burner because we're always so focused on our oncologist or our surgeon. And so I think being able to kind of go behind the scenes like we did tonight to really talk about the ins and outs of nuclear medicine and the role that that plays in breast cancer has been game changing. So thank you all for your time tonight. I really appreciate you joining Breast Cancer Conversations and sharing your personal experiences and your expertise in this area. And thank you everyone for listening to our show. I would like to acknowledge that all of the information on our podcast are from personal experiences and are not a substitute for professional medical advice. You should always contact your medical care team. If you're looking for specific topics or would like to be a guest on our show, please feel free to reach out to me. My email is laura@survivingbreastcancer.org. Until next time, keep on thriving.